Welcome back to Roadmap to Residency. Today we are tackling white blood cell disorders for Step 2 clinical knowledge. This is not a textbook lecture. We are going to break down question stems the way the boards actually ask them, teach you to pattern match in seconds, and show you exactly how to eliminate distractors. If this is your first time here, tap that subscribe button and hit the bell so you never miss a high-yield walkthrough. Drop a like right now so the algorithm brings this to every student prepping for board day. Let us get into it. Here is what you will walk away with. First, the test-taking strategies that separate good scores from great scores on white blood cell questions. Second, the buzzwords that let you pattern match to a diagnosis before you even finish reading the stem. Third, a method for eliminating wrong answers fast. Because on a timed exam, that is how you bank minutes for the tough questions. And fourth, how to pick the best next step when two choices look right, which is where most students lose points. Pair this video with first aid, pathoma, and your UWorld question bank for maximum retention. Before you touch the answer choices, ask two questions. Is this presentation acute or chronic? And how old is the patient? Acute leukemias and neutropenic fever look sick and decompensate fast. Chronic leukemias and lymphomas smolder for weeks to months. Then layer in age. Children get acute lymphoblastic leukemia. Middle-aged adults get chronic myeloid leukemia. Young adults get Hodgkin lymphoma. Older adults get chronic lymphocytic leukemia. This two-step filter narrows your differential before the answer choices can trick you. These three buzzwords show up on nearly every white blood cell question. Auer rods mean acute myeloid leukemia. If the patient is also bleeding with a coagulopathy, it is the M3 subtype, acute promyelocytic leukemia, and the treatment is all-trans retinoic acid. Philadelphia chromosome positive in an adult means chronic myeloid leukemia, and the answer is imatinib. Reed-Sternberg cells with painless lymphadenopathy in a young adult mean Hodgkin lymphoma. Memorize these three trigger word patterns, and you have already answered a big chunk of the questions you will see. Here is your first case. Read it carefully. A 52-year-old woman on chemotherapy for breast cancer spikes a fever. Her absolute neutrophil count is 400. Pause the video right now, pick your answer, and then keep watching. The trap here is the lack of a source. Students see no cough, no dysuria, and assume they have time. They do not. I am going to walk you through exactly how to eliminate every wrong choice on the next slide. Let us break this one down. The moment you see a cancer patient on chemotherapy with fever and an absolute neutrophil count below 500, you are looking at neutropenic fever, a medical emergency. No source is required for the diagnosis. The rule is cultures first, antibiotics within 60 minutes, with a broad-spectrum agent like cefepime, piperacillin tazobactam, or meropenem. Observation kills the patient. Oral antibiotics are too weak. Waiting for culture results wastes the hour when mortality rises. Granulocyte transfusions are not standard. Review this pattern in first aid under oncologic emergencies, and you will see a near-identical question in UWorld. If this breakdown helped, smash that like button and subscribe for the next case. Second case. A 70-year-old man with severe cellulitis has a white count of 52,000 with a massive left shift. At first glance, this could be chronic myeloid leukemia, but the question wants the test that tells them apart. Pause, pick your answer, and then we will walk it through. The distinguishing test is the leukocyte alkaline phosphatase score. In Leukemoid reaction, the neutrophils are mature and healthy, so the score is high. In chronic myeloid leukemia, the malignant cells have lost that enzyme, so the score is low. Use these clues. Clear infectious trigger, no splenomegaly, and the left-shifted cells still look normal. That is Leukemoid reaction. The Philadelphia chromosome and basophilia are hallmarks of chronic myeloid leukemia, not Leukemoid reaction. This concept is covered beautifully in Pathoma Chapter 7 and in sketchy pathology videos on myeloproliferative disorders. Like and subscribe so this content keeps coming to your feed. Case 3. An older man with fatigue, bruising, bleeding gums, pancytopenia, and Auer rods on the smear. The kicker is he is also bleeding from his intravenous lines with a prolonged prothrombin time and low fibrinogen. Auer rods plus coagulopathy is a signature pattern. Pause and pick your answer. Auer rods equal acute myeloid leukemia. Coagulopathy equals disseminated intravascular coagulation. Together they equal acute promyelocytic leukemia, the M3 subtype, caused by the translocation between chromosomes 15 and 17. The correct answer is all-trans retinoic acid. You start it the moment you suspect the diagnosis, even before confirmation, because the coagulopathy can kill the patient. Imatinib is for chronic myeloid leukemia. Rituximab targets B cells. Vincristine and prednisone are for acute lymphoblastic leukemia. Transplant is later, not first. Pathoma and UWorld hammer this exact scenario. If you got it right, drop a like. Case 4. Middle-aged man, massive splenomegaly, white count of 90,000 with a full myeloid spectrum including basophils, and a low leukocyte alkaline phosphatase score. This is classic chronic myeloid leukemia. The question is, which test confirms the diagnosis? Pause and pick. The answer is fluorescence in situ hybridization or polymerase chain reaction for the BCR-ABL fusion gene. That fusion gene comes from the translocation between chromosomes 9 and 22, also known as the Philadelphia chromosome. First-line treatment is imatinib, a tyrosine kinase inhibitor. CD20 is a B-cell marker used in lymphoma workups. Bone marrow blasts above 20% would make this acute leukemia, which this patient does not have. JAK2 mutations belong to other myeloproliferative disorders. Monospot is for Epstein-Barr infection. First aid and sketchy pharmacology cover this perfectly. Subscribe for more rapid-fire walkthroughs. Case 5 is a pediatric classic. A 4-year-old with fatigue, pallor, bone pain, bruising, and painless lymph nodes. Flow cytometry shows terminal deoxynucleotidyltransferase plus CD10, 19, and 20 positive cells. Pause and pick the correct diagnosis and first-line treatment. This is B-cell acute lymphoblastic leukemia, the most common pediatric cancer. Terminal deoxynucleotidyltransferase is your marker for lymphoblasts. CD10, 19, and 20 confirm B-cell lineage. First-line therapy is combination chemotherapy with vincristine, prednisone, and an anthracycline, plus intrathecal methotrexate for central nervous system prophylaxis. Do not forget that prophylaxis. Acute myeloid leukemia would show Auer rods and myeloperoxidase positivity. Chronic lymphocytic leukemia is for older adults with smudge cells. Burkitt lymphoma has a starry sky biopsy pattern. Mononucleosis shows atypical lymphocytes, not blasts. First Aid Pediatric Oncology section and Boards and Beyond videos cover this perfectly. Hit that like button if this case clicked. Case 6. A 72-year-old man, feeling well, is found to have a white count of 30,000 on routine labs. He has small, painless lymph nodes. The smear shows smudge cells. Flow cytometry confirms a CD5 positive, CD23 positive B-cell population. Pause and pick what to do next. This is chronic lymphocytic leukemia, the most common leukemia in older adults. The correct answer is observation with routine follow-up. Early treatment does not prolong survival when the patient is asymptomatic. Treatment is reserved for symptomatic disease, cytopenias, or bulky adenopathy, staged using the Rye or Binet systems. Watch for autoimmune hemolytic anemia as a complication, and for transformation into a high-grade lymphoma called Richter transformation. Chemotherapy and transplant are not first-line in asymptomatic disease. All-trans retinoic acid is for acute promyelocytic leukemia. BCR-ABL testing is for chronic myeloid leukemia. First Aid and the UWorld Question Bank love the watch and wait principle. Subscribe for more. Case 7. A 24-year-old man with a painless, rubbery supraclavicular mass, drenching night sweats, weight loss, and fever. He also has lymph node pain after drinking alcohol. Biopsy shows binucleated cells with Auer nucleoli. Pause and pick your diagnosis. This is Hodgkin lymphoma. Reed-Sternberg cells with Auer nucleoli are pathognomonic. The alcohol-induced lymph node pain is a famous, though uncommon, Hodgkin buzzword. The age peak in the 20s fits too. B symptoms, which are fever above 38 degrees, drenching night sweats, and weight loss over 10%, upstage the disease and worsen prognosis. Hodgkin spreads contiguously, node to adjacent node, which is why staging uses computed tomography and positron emission tomography. Diffuse large B-cell lymphoma lacks Reed-Sternberg cells. Mononucleosis lymphadenopathy is tender. Chronic lymphocytic leukemia is for older adults. Tuberculous lymphadenitis would show caseating granulomas. First-line therapy is the ABVD regimen. Pathoma and Sketchy nail this distinction. Drop a like if this pattern is now locked in. Last case. An 8-year-old boy from Equatorial Africa with a rapidly enlarging jaw mass. Biopsy shows a starry sky pattern and a translocation between chromosomes 8 and 14 involving CMYC. Before chemotherapy, what must you anticipate? Pause and choose. This is Burkitt lymphoma, an aggressive non-Hodgkin lymphoma. The starry sky pattern and the CMYC translocation are the giveaways. The correct answer is tumor lysis syndrome. Burkitt has the fastest cell turnover of any human tumor. When chemotherapy hits, cells rupture and dump potassium, phosphate, and uric acid into the blood, causing hyperkalemia, hyperphosphatemia, hypocalcemia, and acute kidney injury. Prevent it with aggressive intravenous hydration plus allopurinol or rasburicase. Cardiomyopathy, hemorrhagic cystitis, and neuropathy are chemotherapy side effects that come later. Typhlitis happens during neutropenia, not immediately. First Aid and UWorld have this exact question. Like this video if you got it. Quick recognition pearls to lock these 4 leukemias in memory. Acute myeloid leukemia. Adults, Auer rods, myeloperoxidase positive. The M3 variant is acute promyelocytic leukemia with disseminated intravascular coagulation, treated with all-trans retinoic acid. Acute lymphoblastic leukemia. Children, bone pain, terminal deoxynucleotidal transferase positive, treated with combination chemotherapy and central nervous system prophylaxis. Chronic myeloid leukemia, middle age, massive spleen, Philadelphia chromosome with BCR-ABL, low leukocyte alkaline phosphatase, treated with imatinib. Chronic lymphocytic leukemia, older adults, smudge cells, CD5 and CD23 positive B cells. Watch and wait. Match age plus smear finding before you read the answers. That one habit will save you time on every leukemia question. That wraps up white blood cell disorders. Remember, test taking beats memorization. Work through UWorld a second time, paying attention to every wrong answer. Use First Aid as your anchor. Lean on Pathoma and Sketchy for pattern recognition. If this walkthrough helped, please like this video and subscribe to the channel for more high-yield board case breakdowns every week. For one-on-one expert tutoring and residency application advising, visit roadmap2residency.com. Our tutors and residency advisors have been through the match and will guide you from your first practice block all the way to match day. Thanks for studying with us. Good luck on board day, and we will see you in the next case.